Welcome everyone to today's webinar. This presentation will begin in less than 2 minutes. Welcome to this IAS-USA webinar. Today is Tuesday, March 15th, 2022. My name is Jose Francisco, and I'm a project manager at IAS-USA. We are excited to host part 1 of our 2-part CROI 2022 update webinar series. Today's presentation will discuss highlights and clinical research from the conference. We are delighted to have our CROI 2022 clinical chair, Dr. Abrams, Professor of Epidemiology and Pediatrics at Columbia University, who will moderate our question and answer session at the end of this presentation. I would now like to introduce Dr. Abrams, who will also go over our introduction slides. Welcome, Dr. Abrams.
Thanks, Jose. I'm really pleased to be here today, and thank you everyone for attending. And I'll start with a few housekeeping points. So neither presenter nor moderator have any financial disclosures to share. The IAS-USA designates this live activity for a maximum of 1.25 CME credits. Next slide. And this webinar is also approved for 1.25 hours of ABIM MOC points in nursing, pharmacy, and pharmacology credits. Generous support for this activity has been received from the contributors noted on this slide. We are very grateful. The on-demand recording and slides from this webinar will be available within 24 hours after the live broadcast at the IAS-USA website. So most of you are really quite familiar with how to navigate these webinars. When we do poll questions, a separate window will open, show the questions, you can respond, and then we'll display the results. We encourage you to submit questions throughout the presentation, and then of course during the question and answer period, please use the Q&A button. The chat will be open throughout, but not for questions, for comments, and to chat with your friends. Okay, so let's go to the first poll question. Did you attend CROI 2022? So thank you for responding. 17% of individuals attending the webinar attended CROI, 83% did not. So you're in for a real treat today. So at this point, it's my pleasure to introduce the speaker, who is Dr. Roy Gulick, MD, MPH, the Rochelle Belfer Professor in Infectious Diseases, and Chief of Infectious Diseases, and the Division of Medicine at Weill Cornell Hospital, right across the way from us, downtown in New York. So over to you, Dr. Gulick. Thanks.
Great, thanks, Elaine. Can you see my slides okay?
Yes, there's the slide I was looking for.
Okay, great. So welcome everyone. Beware the Ides of March, but here we are together for the first of a two-part series to update what happened at CROI 2022. And I will be taking on clinical research with a focus on antivirals. Our learning objectives, I want to discuss the recent findings from clinical studies in the fields of HIV, as well as COVID-19, and what the implication of these data might be for state-of-the-art treatment strategies. Second is to interpolate these data into clinical practice, and then to identify analytical approaches for treatment interventions. Let's start with a couple of pre-test questions. The first is, at CROI 2022, the third case of HIV cure was reported in a woman with well-controlled HIV who developed acute myeloid leukemia. Which of the following is true about this case? Number one, the participant was mixed race and lived in a developing country. Two, participant received systemic chemotherapy, but not total body irradiation. Number three, participant received a bone marrow transplant from a donor with the delta 32 deletion in the gene coding for the CCR5 receptor. Or four, the participant never experienced graft versus host disease. Please go ahead and vote. Which is true? Okay, so the most popular answer by, and the majority of people voted for number three, the participant received a bone marrow transplant from a donor with the delta 32 deletion in the gene coding for the CCR5 receptor. And then the second question is, at CROI 2022, follow-up of HIV treatment naive and treatment experience studies, as well as prevention studies of Lenacappavir, an HIV capsid inhibitor, were presented. Which of the following is true? Number one, Lenacappavir, or Len, is cross-resistant to HIV entry inhibitors, for example, Fostemsavir. Two, Len is under study as HIV prevention, dosed orally once every 2 months. Three, Len is under study as part of an HIV treatment regimen, dosed subcutaneously every 6 months. Or four, resistance to Len emerges with substitutions in the protease. Which is true? Okay, so the most popular answer, 3/4 of you said, Len is under study as part of an HIV treatment regimen dosed every 6 months subcutaneously. All right, those are our pre-test questions. So CROI 2022. Well, there were over 3,400 attendees from 86 countries, and 40% of attendees were ex-US. CROI this year, as you probably know, was completely virtual. There were over 1,500 accepted abstracts and 38 accepted late breakers, and the acceptance rate a bit higher than in recent years. Over half of both regular and late breakers were accepted. I won't try to cover all 1,500 plus abstracts today. I'm going to focus, as I said, on antivirals. So we're going to talk about HIV antivirals, as well as SARS-CoV-2 antivirals. Well, before we get to that, the top stories at CROI 2022, some of these made headlines around the world. And the first one was the case that we've already referred to, the third cure of HIV. Yvonne Bryson from UCLA presented a case report from a clinical trial called Impact P1107. We're all familiar with the two cases of HIV-1 cure that preceded it. Timothy Ray Brown was the Berlin patient, 2009, who had well-controlled HIV infection, then developed AML, underwent chemotherapy, total body irradiation, and then his oncologist had the idea, because he needed a bone marrow transplant, to find one with the delta 32 homozygous deletion. He did experience graft versus host disease, ultimately stopped ART, and had no evidence of HIV infection, as you know, and has been well published. He survived that bone marrow transplant over 12 years, thought to be cured of HIV, and unfortunately, in 2020, died of a recurrence of his leukemia, but is considered the first person to be cured on the planet. Number two is a man named Adam Castillejo, who lives in London. He developed Hodgkin's lymphoma in the setting of well-controlled HIV, underwent a stem cell transplant with chemotherapy, conditioning, and irradiation, and then received blood stem cells from someone with the delta 32 deletion again. And this was well matched by HLA type. He too developed graft versus host disease, but when the dust settled, was able to stop his ART and is now 30 months out without evidence of HIV. So two cures really in just a little over 10 years. Well, why only two? Everyone's been screening people who develop cancer that requires bone marrow transplantation. But the issue is, how do you find these delta 32 deletions, someone who's homozygous for that? This is a rare mutation, less than 1%. You probably know it's most common in people of Northern European descent. But what you may not know is that there is no routine screening of bone marrow or donors. And so the pediatric group began to talk about cord blood banks as a potential solution. So with your standard adult unrelated grafts, you give a high cell dose from that, and they rapidly engraft in the bone marrow. However, you need a stringent HLA match because of the risk of graft versus host disease. The advantage of the umbilical cord blood grafts is, number one, they're banked, they're readily available for screening, and you need a less stringent HLA match because of a lower risk of graft versus host disease. Well, what are the disadvantages? There's a lower cell dose, and sometimes engraftment is delayed, putting the person at risk. So one potential solution is to combine, so to do two things, to give a cord graft, but also give an adult graft. And that was what was done in the case we're going to describe. So Impact P1107, Impact is one of the NIH-funded networks to do HIV research, and they developed an observational study to look at cord blood transplant specifically that had been screened for the delta 32 deletions. And they potentially could have enrolled children or adults living with HIV-1 who required a transplantation for an underlying disease, and most likely that would be cancer. So it was designed to screen cord blood units, and this was an impact study also co-endorsed by the Adult AIDS Clinical Trials Group, another NIH network. And out of that protocol came a case report of a woman of mixed race who was diagnosed with acute HIV in 2013 and then developed an aggressive leukemia, aggressive AML 4 years later in 2017 in the setting of well-controlled HIV infection, and was thought to need a transplantation for cure of her leukemia. She enrolled in this study and had a partially matched CCR5 delta 32 deletion cord blood unit. And that was given together with one of her relatives' PBMCs that was also matched. And that transplantation occurred in 2017. Again, she got the cord blood, but she also got some cells that were matched from a relative. Now, what you may not have heard is that this took place right here in my home city of New York. And in fact, my home institution was where this was done. So this is a photograph of two of our transplantation attendings here who took care of her. And many of you will recognize my colleague in infectious disease, well known in the HIV community, Marshall Glesby, who had great input into the case as well. So here's a diagram of what happened to this woman. She was diagnosed with HIV, went on antivirals, and promptly had a drop, as we would expect, shown in blue in her HIV viral load. Again, she was diagnosed with the leukemia within several years. She had a couple blips there, but was mostly undetectable, enrolled in this study, and then underwent chemotherapy and total body irradiation, and then had this haplo from her relative and cord transplantation with the Delta 32 deletion. Well, the transplant was unremarkable. She was able to be discharged, importantly, never developed graft versus host disease, and was quite stable, followed on her ART for quite some time. And then at 3 years post-transplant, people began to talk about interrupting her antivirals because no trace of HIV infection could be found. She did elect to stop them. And then at the time of the presentation, 14 months later, had no evidence of HIV off her antiretrovirals. So she is considered to be cured. And here are markers of HIV that were followed in her, both pre-transplant and then post-transplant. And ATI is the treatment interruption of her antiretrovirals, ATI, antiretroviral treatment interruption. So you can see evidence of HIV-1 DNA shown in the red dots or in the blue squares, 2 LTR circles showing evidence of HIV DNA. Both of these declined and remained undetectable. In the orange triangles is an assessment of her reservoir, the replication competent part. You can see that going to very low, if not undetectable levels. And then her viral load is shown in purple. She did have one blip several weeks in and then never had another. So essentially at the end of the day, no evidence of HIV infection. These are her specific antibody responses. She had quite a number of bands. These are the controls. You can see at the time that she entered the protocol, bands for the prominent proteins of HIV, and then began to lose them by week 15. And then, as you can see, never regained them, including after stopping her antiretrovirals. So what can we conclude about this case? She is the first US woman, that's important, and of mixed race, that's important, who was living with HIV, who successfully transplanted with the Delta 32 deleted haplocord stem cell transplant. And I didn't mention this, she had 100% engraftment of the cord blood cells and is felt to be in HIV remission for now 16 months, or what we would say cure. She also has durable remission of her leukemia, as you can see. So no viral rebound, no detectable reservoir, and undetectable immune responses going out well over a year, including HIV DNA by PCR. And really interesting about this case is that clinically she's quite well and never had graft versus host disease. So the 2 previous cases where I emphasized this, that was thought to play a major role in how those 2 individuals, the Berlin and the London patients, basically fought off HIV perhaps and became cured, was part of this graft versus host reaction. This woman never had that. So stimulating for the research field of HIV cure. Well, another headline that made the medical journals anyway was a study called the Anchor study. And this is treatment of anal high-grade squamous intraepithelial lesions to prevent anal cancer. Why is this important? These are the rates of anal cancer in all individuals living in the United States. And you can see men in blue, women in pink, and that the incidence of invasive anal cancer has been increasing since the 1970s. Well, in parallel, cervical cancer has been decreasing greatly. And why is that? Because we have the screening test for cervical cancer, the pap smear, and we have a treatment to treat it early so that cervical cancer does not develop, which is ablation. And that has proved remarkably effective for reducing the incidence of cervical cancer. Well, why can't we do that for anal cancer? And the answer is the screening and ablation really has never been evaluated. And that's what the anchor study did. So the study population were people living with HIV who were at least 35 years old. And they were screened, and if they were found to have HSIL, which is high-grade squamous intraepithelial lesion, then they were enrolled and randomized into the study. If they had cancer, they were referred for treatment of the cancer. If they didn't find high grade, but less grade, the intraepithelial neoplasia, then they were not enrolled, but sent to clinical care. So this was a study specific of the high grade lesions. What should we do with those lesions? Well, the study enrolled and randomized them to one of two options: either active monitoring, so aggressive periodic looks to see what was going on, or the second arm was treatment, and they could have any of the local ways of treating the intraepithelial lesions. So electrocautery or using topical chemo like 5-FU or an immunomodulator called imiquimod. And they were followed every 6 months. And the primary outcome of this study was the development of anal cancer. So they screened over 10,000 people. And interestingly, over half at screening had biopsy-proven HSILs, the squamous intraepithelial lesions. Over half of men who were screened, over 40% of women, over 60% of transgender had HSIL. They actually picked up 17 cases of anal cancer and referred them for treatment. So the first thing to say is that if you look for it, it's very common to find these high-grade lesions. They enrolled over 4,400 people who were randomized, and the study population was 80% men, 16% women, and 3% transgender. They were well represented by a multitude of race and ethnicities. Just under 80% were gay men, 23% were heterosexual, 7% IDUs. Over 80% of these people living with HIV had suppressed viral loads on antivirals, and their median CD4 count was 600, although half had a nadir count of less than 200. And when the treatment group, over 90% had electrocautery ablation of the lesion. What did they find? What's graphed for you here is time to anal cancer diagnosis. And you can see in the observation group, there were 21 cases of anal cancer. That's over an average of just over 2 years. In the treatment group, the active treatment group, only 9. So that's over a 50% reduction in anal cancer, and that is highly statistically significant, as you can see with a p-value of about 0.03. So based on this highly significant difference favoring the treatment group, the Independent Data Safety Monitoring Board recommended to stop the study and offer everyone treatment. And so that's what happened. And then we will continue to, or the team will continue to follow all individuals who continue to be followed. This is the first study to show that screening and treating high-grade lesions is an effective strategy for preventing anal cancer. And the implications of this are really going to, we'll have to watch, but this should be rolled out as a treatment strategy that can prevent cancer over time. So really important result. Okay, back to antiretrovirals. What did we learn new? Well, the first thing is to look at studies we've been following that show examples of our first-line regimens or our switch regimens, and have been following people to see how durable these are. So David Wohl from UNC presented 2 studies we've been following for a while. First-line treatment, these are called the 1489 and 1490 studies originally enrolled over 1,200 people to one of two state-of-the-art regimens. So TAF FTC bictegravir versus 2 nukes with dolutegravir, both recommended regimens that are used commonly in the field. This was a 3-year study with Olay's open label extension for an additional 2 years. So we're looking at 5-year results here. And if you look at virologic response, so suppression below 50, over 97% of all patients, both the BIC and the dolutegravir groups, in an intent to treat analysis, missing equals 67% if you looked at a strict intent to treat, missing equals failure analysis. So about a third of the patients dropped out of the study for one or more reasons. They then concluded that bictegravir was similar to dolutegravir for 3 years, and that both regimens were durable for up to 5 years. So this really reinforces our first-line regimens today. What about switching? So people on older effective regimens switching to newer drugs. So we heard follow-up from the Tango study that initially randomized 741 people who were suppressed on a TAF-based regimen, and then either switched to the 2-drug regimen of dolutegravir 3TC or to continue their 3 or 4-drug TAF-containing regimen. So this was a switch study. And what we saw here were 3-year results, and that was between 80 and 86% of people who switched, or actually overall in the study, everybody had suppression to less than 40. So they concluded that switching to the 2-drug regimen was non-inferior to continuing the 3 or 4-drug regimens. And then finally, Turner Overton from Alabama looked at another switch study called Atlas 2M that we've been following closely. Over 1,000 people were enrolled who were suppressed either on oral antivirals or on rilpivirine given every 4 weeks. And then they were randomized to continue the injections, cab and rilpivirine, every 4 weeks or to switch to every 8-week injections. And we saw the 3-year data here. Over 85% of all people were suppressed to less than 50. So they concluded that every 8 weeks was non-inferior to every 4 weeks. And as you know, the FDA just endorsed this for cab rilpivirine injections, that they could be given every 8 weeks moving forward. So all 3 of these studies really reinforced what we do today in the clinic. Well, another thing that's happened worldwide is the rapid switch in people taking antiretrovirals in middle and lower income countries to the combination of what's known as TLD, which is tenofovir, TDF, L is lamivudine or 3TC, and D is dolutegravir. Over 80% of the world's population taking antivirals takes this regimen. The question is, was that the right thing to do? So that decision was made because dolutegravir was available and affordable, and the world's population was switched to it. But was that an effective strategy? So we began to see a series of studies to answer that question. This comes from the AIDS Clinical Trials Group. It's study 5381, an observational longitudinal cohort study done in African countries and Haiti. And they looked at different groups who were switched to TLD. And the 2 groups they reported on at CROI 2022 were group 1B. They had a viral load suppressed below 1,000 on their first-line NNRTI-based regimen. So there were over 420 of them. You could see that switch to TLD was well tolerated, less than 1% discontinued for side effects. And the table will show you that 96% of them were able to be suppressed, to continue to be suppressed at 6 months. So switching from an NNRTI to dolutegravir in a suppressed patient maintains suppression in almost everybody. Well, we probably would have guessed that, but we didn't have that data for the developing world. Group 4 is another group you might think would do well. People who'd never been on antivirals before, 179 of them, all started for the first time on TLD. Again, well tolerated, just over 1% discontinued for side effects. And in a strict intent to treat analysis, 85% were able to suppress their viral load to less than 50 copies by the end of 6 months. Again, we probably would have guessed both these groups would do well, but the fact is, here's data to say they do. Now, still coming on the study are more perhaps interesting groups. So 2 groups with detectable viral loads, either on an NNRTI or a PI, switching to TLD, and then another group who is suppressed on a protease inhibitor containing regimen. And then there's group 3 who starts TLD in the setting of a rifampin containing TB regimen. So we have to wait for those results to come. Another study that looked at this was from Zambia called the Viscend study, looking at second-line dolutegravir versus PI-based ART. They enrolled people living with HIV on TDF, 3TC, and NNRTI, either efavirenz or nevirapine. And as you know, that was the regimen that was used commonly here in the US and throughout the world for many years. Over 1,200 people enrolled. They were separated into 2 arms, one with virologic suppression and one with detectable viremia. So the suppressed group was randomized to one of 2 options. Both got dolutegravir and then either TDF or TAF and 3TC or FTC. So this is essentially a switch study, going from an NNRTI regimen suppressed to one of those 2 regimens. More arms, arm B with the detectable viremia had 4 choices, the same 2 arms as above, so dolutegravir with 2 nukes, and then what would be the clinical state of the art and recommended is to go from an NNRTI to a PI containing regimen. So you can see boosted lopinavir or boosted atazanavir, and to switch the nukes. If someone's on tenofovir, the WHO guidelines say switch to zidovudine. All right, how did they do? Well, the group that was suppressed, as you would guess, did well with the switch to either dolutegravir with TAF FTC or dolutegravir with TDF 3TC. So intent to treat analysis, 74 to 80%, or the snapshot analysis at week 48, you can see 86 to 90% are suppressed. That doesn't surprise us. What about the group with detectable viremia? Well, you can see the responses here. In intent to treat analysis, the 2 dolutegravir arms look to do better than the 2 PI and zidovudine containing arms. And it's even more dramatic if you look at a snapshot at week 48, dolutegravir arms in the 80 percentiles and the PI zidovudine arms in the 70 to 80%. So if you look at a non-inferiority analysis, the first thing to know is that TAF FTC was non-inferior to TDF 3TC when combined with dolutegravir. And that was true both for the suppressed people and for the people with detectable viremia. But importantly, in people with detectable viremia, dolutegravir-based ART was superior to either of the boosted PIs with zidovudine. And the implications here are that guidelines could be impacted, that it was better to keep the nuke with tenofovir than to switch to zidovudine, and better to go to an integrase inhibitor than a protease inhibitor for second line. Another study that looked at second line from Africa called the Nadia study was previously presented at last year's CROI and then published. This was a 2x2 factorial open label non-inferiority study with a margin of 12%. They looked at people failing an NNRTI containing regimen, and they did resistance information on the nukes, but that information was blinded. The investigators remained blinded to that choice. Over 60% of the participants were women, over half had a CD4 less than 200, and nearly a third had a viral load over 100,000. What was the study treatment? Well, they were randomized either, remember they had been on TDF, 3TC, and NNRTI. They were randomized to either continue TDF or switch to zidovudine, as in the guidelines, continue 3TC, and then the third agent was either boosted darunavir or dolutegravir. And what did we learn? Well, first of all, baseline resistance was quite remarkable. So 50% had a K65R, and over 50% had intermediate phenotypic susceptibility to tenofovir. As you would guess, over 80% had the M184V and over 90% phenotypic resistance to 3TC. So lots of nucleoside resistance walking into the study. But the good news was whether you looked at less than 400 or less than 50 at week 48, the arms did well. So we'll go with the less than 50, 81% in the TDF, 80% in the zidovudine group, not statistically different. Darunavir, 80% suppressed versus dolutegravir, 81%. Again, not statistically different. When they did the non-inferiority look for second-line therapy, TDF was non-inferior to zidovudine, dolutegravir non-inferior to darunavir. Well, that's what we already knew. What did we learn at CROI 2022? Well, we saw the 2-year results. It turns out the primary endpoint for the study is viral load less than 400 at 2 years by the FDA snapshot analysis. So what did they find? Again, people did well for that second year. So about 90% of the dolutegravir group, 87% of the darunavir group were less than 400. And you can see that excludes a margin of 12%. So they concluded dolutegravir non-inferior out to 2 years. And then looking at the nukes, 92% of TDF, 85% of zidovudine. That is statistically significantly different. It includes that 12% margin. So this shows superiority of tenofovir. Again, this has the potential to impact guidelines. Failing a TDF regimen looks like you should not switch to zidovudine in your next regimen. And tenofovir versus zidovudine didn't really matter with the second drug. Both groups did comparably. And as you might expect, the number of active nucleosides in the background therapy, if you had one or more than, well, this is actually interesting. If you had more than 2 active nucleosides, response rates were not as good. That's counterintuitive, right? Well, it's based on a small number, but the interpretation here is people who had that many nukes that were still active probably were not taking their nukes regularly. But you can see if you had 1 or 0 active nukes, people did well, about 90% suppression. There was resistance seen, a handful of cases, 6 in the dolutegravir group, interestingly 5 with zidovudine, none in the darunavir group. And they concluded there were high levels of virologic suppression with either dolutegravir or darunavir, but the TDF was superior to zidovudine in second-line therapy. And then one last one, switching from second-line therapy, what should you do? This is from Kenya. So it took people who were on their second-line protease inhibitor-based ART together with nukes and were suppressed and had no prior integrase inhibitor. Over 760 people randomized to either change to dolutegravir-based ART or continue their protease inhibitor-based ART. And what did they find? Again, a switch study. You'll assume that they did well. This is a snapshot at 48 weeks. And you can see about 90% of all patients were suppressed to less than 50. So they concluded switching to dolutegravir was effective. So putting all these things together, it looks like dolutegravir-based ART is working in multiple different scenarios in lower and middle income countries. Reassuring. Another interesting study was from the AIDS Clinical Trials Group 5324 study. And this was ART intensification for cognitive decline. As you know, we've debated over the years how important is the CNS or brain levels of antiretrovirals, and is that associated with cognitive decline or cognitive improvement? This was a phase 4 open label randomized study. We enrolled people with HIV on ART, but not integrase inhibitors or Moraviroc, with a suppressed viral load to less than 20. And then they did neuropsych testing, and they had to be at least 1 standard deviation off the mean of these standard neuropsychiatric test results. Altogether, 191 people enrolled. Their average age was 53. Over 70% were men, mixed race and ethnicity, high CD4, average was 683. And in terms of neurocognitive impairment on those psychiatric tests, interestingly, a third were completely asymptomatic, 56% had mild deficits, and 9% had frank dementia. And what did we do? Well, the study treatment was continue the present regimen or add dolutegravir or add dolutegravir and Moraviroc. And these newer agents, dolutegravir and Moraviroc, were picked because of their levels that they can achieve in the central nervous system. And they were evaluated over time. So what were the results? Well, the top is a Z-score that was looking at that dementia questionnaire. And you can see all three groups had rises here. So the standard regimen with no additions is in yellow, adding dolutegravir in pink, and adding dolutegravir and Moraviroc in black. All groups increased. Why is that? Well, people get accustomed to these neuropsych tests, so you can actually train yourself to do better. But importantly, no statistical difference there. They also looked at a depression score, and you can see all three groups had slight declines in their depression scores over time as well. They looked at specific subsets based on sex, race, study site, efavirenz use, and adjustment for baseline scores, and this did not change the results. So conclusion here was adding dolutegravir with or without Moraviroc did not alter neuropsychiatric or depression scores. All right, what did we learn new about HIV treatment in pregnancy? Well, as you know, there's been a link between dolutegravir and neural tube defects. These data have largely come out of sub-Saharan Africa, but particularly Botswana. We hadn't seen prior US data. So this is the reported data in the US from 2008 to 2019. Here in the US, we use folate in fortification of food. That's in contrast to other countries, including Botswana, which does not do that. So Botswana not supplementing folate routinely, either in food or in pregnancy. The investigators searched over 36 million US pregnancies, and they broke them down into two groups. Some were commercial insurance, over 17 million, and some were Medicaid, over 18 million. In that very large database, they pulled out over 22,000 pregnancies in the commercial database and over 84,000 in the Medicaid database who were women living with HIV. Then they looked at the subset with early exposure to dolutegravir. So that was the risk in the Botswana study. And you could see picked out over 500 in the commercial group and over 2,300 in the Medicaid group. So what did they find? And the answer is they found one case of neural tube defect, a child born with spinal bifida in the Medicaid group. And that was for an incidence of 0.66 per 1,000 live births. But because of this big data set, they could compare other groups. So what about women living with HIV on other antivirals? And you could see the rates of neural tube defects, 0.9 or 0.68 per 1,000 live births. Then they compared that with women who did not have HIV, and they had an incidence rate of 0.76 in the commercial group or 0.91 in the Medicaid group. We'll note that all those rates are approximately the same. There is no increased rate of neural tube defects associated with dolutegravir in the United States. Another study we've been watching is the Impact 2010 study of maternal ART regimens. And we previously published in Lancet last year was the initial part of the study. So they enrolled pregnant women with HIV at 14 to 28 weeks gestation from 9 countries, and they were randomized to one of 3 ART regimens, either TAF-FTC dolutegravir, TDF-FTC dolutegravir, or standard control TDF-FTC efavirenz. And they were followed for about a year, and over 600 women enrolled. Their outcome was viral load less than 200 at delivery. And you can see dolutegravir did better, 98% suppressed versus 91% with efavirenz, and that actually fulfilled superiority criteria. That's published data. What did we learn new at CROI 2022? And that was the impact on the infants. So over 75% of the infants were predominantly breastfed and therefore were exposed to maternal HIV and their antiretrovirals through breast milk. There's something called a Z-score, which is an assessment of infant length for age. And there's a mean, so that's called LAS. And then a mean weight for age is called WAS. And altogether, those two metrics were lower for mothers who took efavirenz compared with mothers who took dolutegravir. And here are the numbers here. So the difference in length was statistically significant, and the difference in weight was statistically significant, favoring dolutegravir. Interestingly, no differences between the TDF dolutegravir arm and the TAF dolutegravir arm. And somewhat surprising, severe stunting was seen in an appreciable number of infants, over 13% on dolutegravir, over 20% on efavirenz. So they concluded that growth overall of the infants was less with efavirenz than dolutegravir, but similar with either TDF or TAF. All right, well, one thing we look forward to every year at CROI is an update on new drugs. For treatment and prevention, I'll remind you that Susan Buckbinder in part 2 of the CROI update is going to tackle prevention. So I'm going to steer towards treatment here. One investigational agent we've been following is Latrovir. This is an adenosine analog, so it's a nucleoside analog. It's a DNA chain terminator, and it inhibits reverse transcriptase by preventing translocation. So it's an NRTTI, nucleoside reverse transcriptase translocation inhibitor. One of the interesting properties is its very long half-life, 50 to 60 hours, which would allow it to be dosed infrequently. It's potent in the test tube and has broad coverage against HIV-1 and 2 and multi-drug resistant strains. It's available in very low-dose oral and also parenteral formulations. And the early published data shows it's quite potent. You can see at the highest doses tested, a single dose at time 0 led to almost a 2-log drop in virus at the highest doses 10 days later. And so it was forwarded into clinical trials with infrequent dosing for both treatment and prevention. So oral daily dosing, well, that's not novel, but they tested some unique dual drug treatment regimens that looked successful. There were pilot studies of weekly oral dosing for treatment. Imagine that. Could we have an ART regimen once a week? Monthly was looked at for prevention. So a single dose once a month, and there was pilot data to support that. And we heard updates, which Dr. Buckbinder will review with you. And then could you give a drug yearly? Well, there are implants with Latrovir. So all of these were moving forward, including oral daily treatment combined with doravirine, the oral weekly prevention as a single agent, or treatment with one of these two new agents, an NNRTI called 8507, or Lenacappavir, the new capsid inhibitor, long-acting injectables combined with Lenacappavir, and then, as I mentioned, implants. Well, what did we learn new? Right before CROI, a press release came out. In a treatment study of oral weekly Latrovir with this investigational NNRTI, they found lymphopenia with dose-dependent decreases in CD4 cell counts up to 30%. And that was in the setting of virologic suppression. So it looked like it might be a lymphopenia toxicity. That was in people with HIV. And then in a PrEP study, Latrovir alone was associated again with 20 to 36% decrease in CD4 cell counts, although in these people without HIV, they still were within the normal range. But it looked like Latrovir is associated with a lymphocyte toxicity. Well, that's very unusual in terms of drug toxicities. No other blood cell lines were affected, so neutrophils, red blood cells, platelets. They went back and looked at the earlier studies of this compound and saw no signal that this was a problem. And so they are considering multiple mechanisms, but are not sure what's going on. And so the FDA, as a result, put a clinical hold on studies with oral, injectable, and implantable Latrovir. So we have to wait and see what happens with this compound. Pretty disappointing. The other new drug that we have our eye on is Lenacappavir, as I mentioned, Len. And this is a capsid inhibitor. So you'll recall HIV binds to the receptor, releases its core, which is transported into the nucleus, and then this capsid disassembles, exposing viral RNA, which is reverse transcribed to viral DNA, used to make proteins and new copies of viral RNA, which assemble with the assembly of the capsid again, and then release as viral particles. So the new capsid inhibitor actually interferes with different steps in the life cycle involving the capsid. Lenacappavir, highly potent in the test tube or on the picomolar range here. It's active against all subtypes. And again, a property of this compound to keep your eye on is its very long half-life, 30 to 43 days. It's available as oral and subcutaneous formulations. Again, in an early antiviral study, a single dose led to about a 2-log drop by the end of 9 days. And that was in phase 1 studies. And then a new sustained delivery formulation. Look at this, subcutaneous given every 6 months achieved. We're looking at target drug levels here. And so they support using Lenacappavir subcutaneously every 6 months. And that launched phase 2-3 studies. And we heard some of these results at CROI this year. So there's a big treatment naive study of Lenacappavir called Calibrate. It's phase 2, randomized, open label, controlled, induction maintenance study. They enrolled ART naive people with viral loads over 200 and CD4s over 200. And phase 2 size study, just over 180 people. They were randomized 2 to 2 to 1. So the first 2 groups got Lenacappavir sub-Q every 6 months and the combination of TAF, FTC, 1 pill once a day. At week 28, the first group dropped the FTC, so it's now a 2-drug regimen. And the second group switched to oral Bictegravir, again, a novel 2-drug regimen. The third group continued TAF, FTC, and Lenacappavir all orally once a day. And the fourth group was the control group, TAF, FTC, and Bictegravir. Well, how'd they do? Well, so we're looking at suppression to less than 50 copies. You can see the 4 groups are superimposable here with about 80 to 90% suppression in all 4 groups. So that includes the 2 control arms, which are oral, but also the Len sub-Q with 1 other antiviral given orally. And here are the specific numbers at week 54, so a year of data. You can see a mixed study population, but again, 85 to 90+% are suppressed to less than 50 copies. So Lenacappavir contributing to novel 2-drug and 3-drug regimens long-term. The other study is called Capella. This enrolled a tough to treat treatment experienced patient group. This was randomized double-blind placebo-controlled study. They enrolled people with HIV who had multi-drug resistant HIV, which they defined as resistant to at least 2 drugs, 3 out of the 4 classes, had detectable viremia, and fewer than 2 fully active agents to go to. And this was a pilot study of 36 people. They continued their present regimen and then started Lenacappavir, first orally, for 8 days. That was the primary endpoint to the study. Okay, well, how did they do? That primary endpoint was the percent with a half a log drop in viral load. You can see close to 90% of the Len group, only 17% of the placebo group, highly statistically significantly different. And according to the new FDA rules of multi-drug resistant studies, that is the result of the phase 3 study. Well, of course, clinically, we want to do better than just 8 days. So they allowed people to optimize their regimen and then switch to sub-Q Len given every 6 months. So here's 15 days of that strategy. Again, you see Len associated with almost a 2-log drop compared with placebo. And then longer term, we saw 6 months of data, 81% of the Len group was able to suppress their viral load to less than 50. Well, that was the old news. What did we learn at CROI this year? We saw updated data. So now 52 weeks of data with that strategy. So optimize the background and add sub-Q Lenacappavir. 83% of people were able to be suppressed through a year. So it looks durable. And as you would imagine, the number of agents in the background does predict outcome. Those with more than 2 active agents, 94% were suppressed at the end of a year. Resistance does develop to Lenacappavir. It's substitutions in the capsid. And the new number we have to learn is M66I, which is the most common mutation that can be selected out on Lenacappavir, although there are others. Is Len active against entry inhibitor resistant viruses? So enfuvirtide, fostemsavir, ibalizumab, Moraviroc. That was the subject of this poster. So they looked at these treatment experienced people, and for every one of those 4 drugs that I just mentioned, some were susceptible and some were resistant. So enfuvirtide, fostemsavir had some resistance, ibalizumab had resistance, and Moraviroc had dual mixed and X4 tropic virus. How did Lenacappavir do in those patients? Well, exactly the same in both susceptible and resistant people. So that's good news, meaning that Lenacappavir susceptibility is not affected by entry inhibitor susceptibility or CCR5 tropism. Can you combine islatravir and Lenacappavir? Well, islatravir is a nuke, so it's primarily metabolized by adenosine deaminase. It's not a substrate or an inducer of the cytochrome enzymes. Lenacappavir, the capsid inhibitor, is a substrate of CYP3A and is also metabolized by uridine diphosphate glucuronosol transferase, thank you, and PGP, P-glycoprotein. But the good news you see here, with or without the other drug, the concentration curves are completely overlapping. So there is no significant interaction between these 2 compounds. All right, what's the update with Lenacappavir? The manufacturer submitted a new drug application back last summer to the FDA for heavily treatment experienced patients with multi-drug resistant HIV. The FDA granted priority review because of unmet need in this population. However, in December, the FDA put a clinical hold on treatment and prevention studies of the injectable, not the oral, Lenacappavir due to vial quality concerns. It was stored in glass vials where there were some concerns. March 1st, so just 2 weeks ago, the FDA did not approve the phase 3 data for Lenacappavir in multi-drug resistant patients because of this ongoing concern about the glass vials. They didn't ask for any new clinical studies, and the manufacturer is going to develop a comprehensive plan to use a different vial type. So hopefully just a hiccup in the availability of this compound. All right, lastly, another virus, COVID-19. What did we learn at CROI 22 about COVID-19 treatment? Well, to remind you, these are the recently updated NIH COVID-19 treatment guidelines. Just on February 1st, I'm one of the co-chairs of these. We've made substantial progress in the last couple of months for outpatients with COVID-19. And specifically for people who are at high risk of progression of COVID due to underlying diseases or their age, the guidelines recommend ritonavir boosted nirmatrelvir, the monoclonal antibody sotrovimab, the IV antiviral remdesivir, and these 3 are highly recommended and preferred. And then if you can't get those, the oral drug molnupiravir. So what did we learn new? Well, sotrovimab is this monoclonal antibody. The emergency use authorization allows intravenous administration. This was a study at CROI that compared IM administration, which would be easier, intramuscular. This is called Comet Tail, randomized, multicenter, open label, non-inferiority study. They enrolled people at high risk of COVID progression who had mild to moderate symptoms of COVID-19. Big study, over 980 people. They were randomized to one of 2 IM doses of sotrovimab or a single infusion, IV infusion of the compound. The study endpoint was disease progression, meaning hospitalization or death. Here's what they found. Over a quarter of the people were elderly, over 65, 85% were Latino or Hispanic. And the lower dose of sotrovimab at 250 IM was stopped early because of increased hospitalizations in that group. So the higher dose went on to be compared with the IV infusion. And here were the numbers. So just under 3% of the IM group versus just over 1% of the IV group had clinical progression. And that fulfilled the criteria for non-inferiority. Remember, the limit was 3.5, they were 3.4. So they concluded IM sotrovimab non-inferior to IV. That has not yet been incorporated in the emergency use authorization. So the FDA are reviewing these data. And then another sotrovimab study looked at the effect of serostatus. So what if you walk in with a positive antibody? Phase 3 randomized multi-center double-blind study looking at outpatients with one risk factor for disease progression and symptomatic COVID. Over 1,000 people enrolled. They either got sotrovimab or placebo. And again, the endpoint was disease progression. Overall, sotrovimab was associated with a 79% decrease in clinical progression. 1% in the sotrovimab group, 6% in the placebo group. And that's what led to its recommendation in the guidelines. For this presentation, they went back and looked at those with pre-existing antibody. 70% of the people enrolled did not have that, but 19% did, and another 11% it was not known. And then they looked at clinical progression. And what you see here is in the negative group, sotrovimab did well, only 1% progressing versus 7% in the placebo group. People who were seropositive for antibodies, 2% progressed versus 4% in the placebo group. So they felt and concluded that sotrovimab was associated with decreased clinical progression regardless of serostatus. And then one last study, molnupiravir. So it's an antiviral agent. It's a nuke analog of cytidine. It's broken down into its active form, so it's a prodrug. It has a unique mechanism of action. It induces lethal mutagenesis in SARS-CoV-2. So it induces mutations that cause the virus to not be able to replicate anymore. It's given orally for 5 days, and a recently published New England Journal study enrolled 1,400 high-risk outpatients with mild to moderate COVID within 5 days of symptoms and followed them for hospitalizations or deaths. And you can see fewer occurred in the molnupiravir group, 7% with progression, compared with about 10% in the placebo group. That is about a 30% reduction and does achieve statistical significance. Although 30% reduction, you can see, is much less than sotrovimab, or for that matter, nirmatrelvir, ritonavir, or remdesivir. This is available too by emergency use authorization, specifically for people when other treatments are not accessible or clinically appropriate. So what did we learn new at CROI? Well, there was an Indian study that was an open label study at 23 sites. They enrolled not high-risk outpatients, but adult outpatients, less than 60 with mild symptoms, and they enrolled over 1,200 people. It was open label, so everyone got standard of care plus minus molnupiravir for 5 days, and their endpoint was hospitalization. And here's what they found. So about 1.5% of the molnupiravir group was hospitalized versus over 4% of the standard of care group, and that's highly statistically different. And they looked at viral loads. So when did people become SARS-CoV-2 PCR negative. And you could see the blue bars are molnupiravir. That occurred in many more patients, particularly early on, than in the standard of care group. So they concluded there was a significant reduction in hospitalizations of outpatients with mild to moderate COVID. All right, lastly, the big news is, when is next year's CROI? So we don't know the dates yet, although the IAS-USA maybe does know this by now, but we do know the city, and it's New York. Oh no, Seattle. So next year's CROI will be in Seattle, hopefully in person. So I want to thank the IAS-USA for sponsoring this, recognize my division and some people who loaned me slides generously for this talk. And let's do the 2 post questions again, post-test questions, and then we'll open it up to questions. So this one is about the 3rd case of HIV cure, which is true. She was of mixed race and lived in a developing country. She received systemic chemotherapy, but not total body irradiation. She received a bone marrow transplant from a donor with the Delta 32 deletion, or she never experienced graft versus host disease. Which is true? See how carefully everyone was listening. Okay, so 63% of you got this correct. She had never experienced graft versus host disease. Next most popular answer, 33%, received a bone marrow transplant. Remember, she got an umbilical blood cord transplant. All right, and question number 2. This is about Lenacappavir. Which of the following is true? Len is cross-resistant to HIV entry inhibitors. 2, Len is under study for prevention, dosed orally every 2 months. 3, Len is under study for HIV treatment, dosed subcutaneously every 6 months. Or 4, resistance to Len emerges in the protease. Oh, that one flashed by quickly. There we go. 90% of you got it right. So HIV treatment dosed subcutaneously every 6 months. Good job. All right, I'm going to stop sharing. And Elaine, happy to try to tackle some questions with you.
Fantastic. Well, thank you for that tour de force. And I particularly appreciate the background that helps us understand what's new and important from CROI. So that was wonderful. So let's start with a question from Brett Douglas, who asks about the remission patient and wanted to know if she had biopsies like the Berlin patient to determine how, that she was, quote, cured.
Yeah, I have to confess that I don't know that. They did significant blood work as I reviewed, looking for evidence of DNA. I don't honestly know if she's been biopsied. You're right, the Berlin patient had a number of biopsies. Do you know yourself, Elaine?
I don't remember it being reported that they did biopsies. So I would say no, or they didn't have the results from them to present it.
I'll have to check with my colleagues, to be honest.
Yeah, okay, great. So Jennifer Lynn asks, will there be new anal cancer screening guidelines based on Anchor?
That's a great question. And you have to assume that there will be, right? I mean, this is a study that showed that screening and treatment prevent cancer. That is so important, right? So we must guess that we will begin to see this influence national guidelines. Remember, anal pap smears are not routinely recommended in most guidelines right now. Why is that? Because we didn't know what to do with the results, but now we do know what to do. So let's wait for it. It's got to come.
So that actually leads right into Valeria Cantus' question, who asked how screening was done. Was it pap smear or anoscopy with biopsy? Do you know that information?
Yeah, they did pap smears initially, and then like they would do with that, depending on the result, they would actively do anoscopy and biopsy any suspicious lesions. And that's how you make the diagnosis there. So that's what they did, pretty standard of care for that study.
Right. So as you're thinking about guidelines, there's more than just, simple pap screening that would have to be in place. There's probably infrastructure to be built.
That's exactly right. And importantly, trained staff who can do this, because
Yes.
you need to learn how to do it.
And one additional question from David Cortu, and again about Anchor, he was asking whether participants were vaccinated against HPV.
Good question. I don't know the answer, but because they were all over 35, it was probably not a routine thing.
Yeah, I was going to give the same answer because it was an older cohort. Yeah. Okay, so let's just pivot back to the
Elaine, we
Yeah.
should say, because we're talking about prevention of cancer, that last question was a really good one. HPV vaccination should prevent cancer as well. And obviously, we need to reinforce that we should do that in our younger patients.
Yes, exactly. And I think, at CROI, the PI spoke very eloquently about, cervical cancer screening and prevention as the model for all of this. And that's right, the ethos there, get all young girls vaccinated, but still we continue to screen. Okay. I think I lost the question. So Terrence Donovan asks, is whether any information, and I'm not sure what this is, any information about Evusheld availability for HIV-infected SOT patients?
So Evusheld is the trade name for a combination of two monoclonals for COVID-19. Okay. So it's tixagevimab and silgavimab. And it's only available for prevention right now. There's some emerging data for treatment, but it's for prevention. And it's specifically available through an FDA EUA, emergency use authorization, for people that you think won't respond to vaccines or who have had severe allergic reactions to vaccines. And so it is available. It's in somewhat short supply across the country, but there are supplies that are available. So this would be for people with moderate to severe immunocompromise from cancer. In our case, from people living with HIV who have advanced HIV disease. So that's defined as a CD4 less than 200 or a prior AIDS diagnosis or symptomatic HIV disease. They would fall into that group and could be eligible for Evusheld. That's the trade name.
Thanks. Okay. Mercy June asks, how will cord blood impact a new diagnosed HIV positive infants and HIV exposed infants?
Not sure what that question's asking.
Yeah, well, I can say that I don't think there's any direct impact. This was an impact initiated study, which is the maternal pediatric network. But presumably if a child requires a transplant, a child living with HIV, they would be potentially eligible for the same process, but there are no plans right now to use this towards cure, let's say, of HIV positive infants.
Yeah, it's specifically for people who need a transplant for another reason, most commonly one of the hematologic malignancies.
Exactly. Okay, so Jake Carmichael asks, is there any data from Viscend regarding metabolic impacts of dolutegravir plus either tenofovir FTC or TAF FTC?
That's a great question. I did not see them report the metabolic outcomes. I assume that you're referring to weight gain, for instance, and I did not see them report those endpoints.
Yeah, I didn't either.
It was a short presentation.
They all were.
Yes.
Dwight Rackley has a great question for you. How do you explain HIV cures to your patients when they ask about being cured?
What I say is that 10 years ago, we didn't even say the word cure because we assumed that it would be, that we couldn't do it. And then we heard about that Berlin patient case, which really charged up the research agenda for cure. So in medicine, if we can see something once, then the question is, can you do it in a much safer way and roll it out to a lot of people? Well, remember what we're talking about right now. We're talking about people with cancer who get chemotherapy, irradiation, and then undergo transplant, either with bone marrow or stem cells or cord blood. There's a 30% mortality associated with any of those procedures. So this currently isn't a strategy that we're going to roll out, but the whole field is charged up about the fact that it does happen. And so can we do it in a safer way? And that's what we're working on now. So what I tell my own patients is keep doing what you're doing. You know, you're undetectable, you're living your life, you're doing well. And yeah, you've heard about 3 cures now, but let's see how it goes. Let's see how the field goes. We need it to be safer before we can offer it to people.
So I think we have time for one last question. And Stephen Knox asks, why is a response rate of 80% okay in switch studies when we expect 95% in naive studies?
Yeah, no, I think you're right about that. It all depends. The devil's in the details. So you're right. Most switch studies, you want to see over 95% of people. You got to go back and look at the specific time point they looked at, and you see if anybody drops out. Obviously, if there are people who continue on the same regimen, should continue to be suppressed. People who switch to a new one, there's always the possibility that a side effect or inconvenience of the regimen could lead to non-adherence. So I agree with you. I think that switch studies routinely should be over 90%. But again, you have to go back and look and see, well, why aren't people suppressed? And most of the studies I presented, it's because people left the study. So they just didn't have the data.
Great. So I'll turn to the hosts and ask if we have time to go on, or should we thank everybody?
Dr. Abrams, if you're able to continue, just to get through the last questions, if you have the availability, as well as Dr. Gulick.
Okay,
I'm
great.
good.
Okay, so we have right now 3 more. One is actually a comment from R. Hernandez. I think speaking about the anchor study, that the system will need to increase capacity for high resolution endoscopy. I think certainly all agree with that.
The system, including the personnel.
For sure, training and continuing to do that, absolutely. So David Palm mentions that there was much gnashing of teeth regarding COVID therapeutic results that only included pre-Omicron data. So sotrovimab activity comes to mind. Were there Omicron-based data teased out?
You're quite correct to make that comment. Almost all of the treatment studies we have were done prior to Omicron. So we have very little data in Omicron. And the study results I showed you were prior to Omicron. So what we're relying on right now is laboratory assessments of susceptibility to Omicron. And the thing we need to say about sotrovimab, and thanks for bringing this up, it has reduced activity against the Omicron virus among the monoclonals. And remember that we've already stopped several combinations of monoclonals because they weren't effective against Omicron earlier. So
Monica Manhander mentions for Evusheld, how do you say that?
Evusheld,
eligibility.
Trade name.
Do you recommend pre-exposure prophylaxis for patients with prior AIDS diagnosis who now have a robust CD4 count over 500? And what do you mean by symptomatic HIV?
Yeah, so I'm just telling you what the definition is. If someone has a prior AIDS diagnosis, but is doing well now and has a CD4 over 500, you really have to say, do they have moderate to severe immune suppression? I don't think you would say that. If their CD4 is less than 200, you would sure say that. If they're symptomatic, that's obviously, and again, that's a loose definition, I grant you, that means that their immune system isn't functioning perfectly. So CD4 less than 200, I think no one would argue with you, particularly CD4 less than 50 is profound immunosuppression, and those people certainly should be prioritized. Some of the others, it's a little more nuanced.
Great. Okay, Orbit Clayton, will Len be added to the standard ART list? And if so, when? And would it be available both here and in the US as well as globally?
So Lenacappavir is investigational right now. What I reviewed for you is that the phase 3 data in treatment experienced people with multi-drug resistance looks favorable, and that the company applied to the FDA for formal approval, but was declined. So they declined because of this glass vial issue. Not a problem with the drug, it's a problem with the container. So we would expect that they're going to generate some data for a new kind of vial and will resubmit. And based on the data I showed you, you'd have to guess the FDA would approve it for multi-drug resistant HIV. And so that would be on the list of approved drugs if that happens. Will it be rolled out around the world? Well, I'm sure people are beginning to think about that as well.
There is great interest, particularly for prevention for that agent, because long acting.
Yes, and Susan Buckbinder is likely to show you some interesting results.
That's poetic. Okay. Any comment about resistance seen in the dolutegravir group in nadia?
A few cases of resistance were seen, I believe, but not a lot, as you can tell from the suppression rates.
Okay, and then one final question from Haneen M. Is there an evolution to NAFLD, NAFLD or NASH in patients with comorbidities who increase weight under DTG or BIC?
I don't know the answer to that question. Do you know, Elaine?
I don't remember the data being presented, not in the short analysis. Okay, so I think there's one very last question, and then I think we'll have to say thank you. So should women with abnormal cervical paps have an anal pap?
I think the recommendation is yes for that. In fact, women with an abnormal cervical pap have an increased risk of having an abnormal anal pap as well. HPV, as we know, can travel in the perineum and be involved with infection in different organs. So yes, women with cervical changes should get an anal pap smear as well.
Okay. Well, we've answered all the questions. I want to thank you personally. I was at CROI and I learned a lot from your presentation today.
Hard to go to everything, right?
Great. And thank everybody for participating, and to IAS-USA for holding this webinar.
Thank you, Dr. Gulick and Dr. Abrams, for that fantastic discussion and presentation. I'll just close off today's webinar. As a reminder to attendees, evaluation and information on how to claim continuing education credits will be emailed to you by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. As a reminder, part 2 of the CROI 2022 update will be on Thursday, March 31st. And here are an additional list of upcoming webinars that we have available for you to register for. Here are our 2 upcoming courses. Again, for more information, please visit the IAS-USA website. Lastly, we have a COVID-19 dialogue scheduled for Friday, April 1st. Again, to review all of our activities and on how to register, please visit the IAS-USA website. Thank you, and this concludes today's presentation.